welcome you this evening. And on behalf of the Elder Care Committee within North Arundel County, I want to say welcome to you. I have another committee members on here, Lori and Sandra. We'd like to thank you for joining us this evening. This evening actually kicks off our Senior Support Week for individuals who are caring for seniors, loved ones, our elders. So we not only wanted to do blessing bags, which we'll be talking about a little bit more on Saturday, but we really wanted to connect our community with resources to support them through this particular journey. So that is the concept behind our NACA Senior Support Week. This evening, I am delighted to welcome Mayor Chaput, who is the program director with the Anne Arundel County Department of Aging and Disability, to share some wonderful information regarding dementia and Alzheimer's and how caregivers can be supported through this particular process. So I will not be long, but I want to thank you and welcome everyone this evening. Thank you.
Thank you. I'm so delighted to be here. If I've met any of you before, I'm not good at names, but I hope I recognize some faces here. And if you know me, I love to talk to caregivers. I love to do training with caregivers. It's a difficult journey that you're on, and I'd like to be a part of it and walk along it with you. So let me go ahead and pull our PowerPoint up here. So again, as Chandra said, I am with our caregiver support programs at the Anne Arundel County Department of Aging and Disabilities. And later on in the presentation, I'm just going to give you a real quick overview so that you know kind of generally what kind of services that the Department of Aging and Disabilities has for family caregivers. So one of the first things that you need to do when you become a caregiver, whether you become a caregiver suddenly because someone has had a stroke or a heart attack or been diagnosed with a chronic disease, or if you become a caregiver gradually, you're taking care of your loved one, doing a little bit more and more as that dementia starts to progress. You need to know your enemy. You need to know what you're dealing with. Since we're talking specifically about dementia tonight, we need to know, to the best of our ability, what kind of dementia are we dealing with. Sometimes it gets a little bit hard. Sometimes some physicians think it's not important, that all dementias progress and it really isn't important to know what kind. But I think for family caregivers, it's very important to know what kind of dementia you're dealing with, because they can all present a little bit differently and they can all progress a little bit differently. So we need to know as much as we can. We can find that out by, working with the physician, but also by looking into the different resources that are out there locally and nationally. So, there's lots of associations and foundations that we can find online. We want to make sure we look at the reputable ones, such as the Alzheimer's Foundation of America, the Alzheimer's Association, the Parkinson's Foundation, the Association for Frontotemporal Degeneration, and all the other different kind of associations that are out there to help us with information and expectations for this journey. It's important to know what's normal and what's not. So again, each dementia may progress a little bit differently, and each person's going to progress through that dementia a little differently because we're all individuals. It's important to keep in mind that you are an active member of the healthcare team, and the professional providers are your partners. So don't be intimidated. Be willing to share information with them. Be willing to ask questions, because you're all partnering together to provide the best care that you can for your loved one. The other thing that you have to really keep in mind is that you need to routinely assess where your loved one is in their dementia, what their needs are, And you also have to routinely assess your ability to provide care, because dementia can be a very long journey. Once someone is diagnosed, they could live for another 5 years, 10 years, 15 years, 20 years. It's a long time. And your health condition may change during that time. Your emotional condition may change during that time. So you need to constantly reassess if you're able to provide the best care. Now, that doesn't mean, if your answer is no, I can't provide the best care, it doesn't mean I'm saying put your loved one into a long-term care facility. It's just that then we need to look at what kind of support services do we need to put in place. One of the other things that you need to accept is the fact that you can't change the outcome of this disease. We can do all we can to make our loved one's life as productive, as comfortable, and as happy as we can make it for them, but we can't change the outcome. We can't change that this disease is going to progress unless we have a miracle over the next, year or 2 years where we find a cure or we find something to stop the disease. And we also need to be keeping aware of, when is palliative care going to be the best option? When is it appropriate to look at palliative care? And by that, it means that we stop looking at other kind of treatments and we just make sure that our loved one is comfortable. So, dementia in a nutshell, dementia describes a group of symptoms that affect our memory, our thinking, and our social abilities, enough to interfere with our activities of daily living. So it's enough to interfere with how a person gets through the day. Generally speaking, when 2 or more of the activities of daily living are affected, dementia is the diagnosis. It isn't a specific disease in itself, but several different diseases can cause dementia. So broadly, there's known to be 3 kinds of dementia. So the first one is what we call reversible dementia. And when I talk to family caregivers who tell me, my dad is 78 and he has dementia, and I'll ask him, when did you get the diagnosis? And lots of times they'll say to me, oh, well, we haven't gotten a diagnosis, but, he's 78 and it runs in the family and, he forgets a lot. Well, we always strongly encourage folks to go ahead and get a thorough checkup from their primary care physician, because there's certain conditions such as infections and depression, medication interactions, vitamin deficiencies, things like that can cause dementia-like symptoms. So someone can seem like they have dementia. They may be confused. They may be having memory issues or cognitive issues. But if we treat the underlying cause, those symptoms go away. So we call that a reversible dementia. And we always want to make sure that we have that thorough workup so we can rule that out. There's also vascular dementia, which is caused by lack of oxygen to the brain, usually caused by strokes or traumatic brain injury. So someone who has a vascular dementia, for the most part, they kind of stay on an even level. So the damage has been done, what's affected has been affected, but they don't get any worse unless they have another stroke or another head trauma. What we're going to be talking about tonight is progressive dementias. So progressive dementias, there's more than 100 different kinds. Alzheimer's disease is the one that we hear the most about. It's the one that most of the research has been going on. But in my job, I'm also hearing more people that are being diagnosed with frontal lobe dementia, people that are being diagnosed with Parkinson's, with Lewy body dementia. So there's other ones that are out there also. It seems like Alzheimer's is the one that gets the most noise. Most people recognize that. It's important to realize that dementia is not a normal part of aging. Just because we get old does not mean we're going to have dementia. The older we get, the higher our risk becomes, but it doesn't mean that we're going to develop dementia. So I like our pretty rainbow here, but unfortunately the pretty rainbow kind of represents some things that are not so pretty and actually kind of sad in a sense. So if you look at the right-hand side where it says mild and level 5, that's generally where someone is in the dementia at the time we get the diagnosis, especially when we're talking about Alzheimer's disease. So it's a misnomer to think that, oh, we just got diagnosed, so we're in the early stages. Unfortunately, that's not true. By the time we get diagnosed, and again, particularly with Alzheimer's disease, that disease has already been eating away at the brain cells, has been destroying the brain cells for anywhere from 10 to 20 years. So there's already been a lot of damage done. So at the time we get a diagnosis, that individual has the cognitive ability, so the ability to make a decision, a good decision. They have a cognitive ability of a 12-year-old to a 9-year-old. And I go backwards because that's what's happening in this disease. As the disease progresses, the individual is regressing. Now, this is really difficult at this time because most people, when they're diagnosed, they still look relatively healthy. And most people wouldn't know something was wrong with them if they're not spending long amount of time with them. So, they can carry on a social conversation for 20 minutes, 30 minutes, and someone wouldn't recognize that something was wrong. It's difficult because at that point in time, they have good days, they have bad days. They know something's going on. They recognize that things are going to get worse. And, they may be angry, they may be sad, because they know there's going to be more losses and they're going to try to hang on to as much as they can. As family members, it's difficult because we have to make a decision on certain things that affect their independence. So at that point in time, we have to think, would you let the 9-year-old drive the car? If you had a 9-year-old child, would you give the 9-year-old child the keys to the car? This individual who has just been diagnosed still knows how to drive. They have the procedural memory of how to drive. They know how to put the key in the ignition. They know how to put it in park, and they know how to put it in reverse, and they know how to put it in drive. They know the gas pedal and the brake pedal. But cognitively, they may not be able to make a good decision because of other things that are going on in the brain. Would you let the 12-year-old in your house handle the family finances? Okay. So for these individuals that all their lives have taken care of paying the bills, they may not be cognitively able to do that anymore. But they don't understand that, and they're not willing to give that up. So this can really become a time of struggle between the caregivers and the person who is diagnosed with dementia. The next stage, as you see, is really broad. We're looking at 9 years to 18 months. And for those of you that have raised children, that have been around, nieces and nephews, you know that someone who is from 18 months to 9 years, they are learning an awful lot during that time. They have gone from, learning how to stand up and take their first steps, having the unsteady walk, to really learning to walk well and to be able to run. They've learned their language, from a few words to be able to put words in a sentence, to be able to have conversations. All of these things they've learned, but as this dementia progresses, they're going to regress and they're going to go backwards in time and they're going to lose their abilities. They'll lose language, they'll lose their mobility, and they'll continue to lose their cognitive skills, and they'll lose their memories. The final stage is that kind of 18 months to the point where they need total care. So again, it's looking at, an infant going up to that toddler stage and looking at it in reverse. So as I said, it's a pretty picture, but it doesn't represent anything pretty that's going on. So too often people, including some medical staff, often think that dementia is only about memory loss, but it also is functional loss. As I said earlier, it affects our speech, it affects our cognition, it affects our executive functioning, our senses, our motor skills, our ability to sequence. And so we call these changes our 5 A's of dementia. And I could spend an hour just talking about this piece of it, but let me just kind of go through it quickly for you. So our absence of executive function, these individuals, this is usually when the frontal lobe has been affected. They have poor judgment making skills. They're unable to make a decision. So if we get back to restaurants, so we can go in a restaurant and eat, and you hand them the menu and you say, what would you like? And they would probably not be able to make a decision, and they would say, I'll have what you're having, or I'm not hungry. Okay, so they don't have an ability to make a decision. It also comes in fact with the driving. So if they're in a car and they're driving a route that they're familiar with, but because of road construction, they can't turn on the road that they're used to turning on. They don't have the ability anymore to decide how they're going to get home. So they can't make a decision. They can't adjust to a change. They also have a loss of filter. And so whatever comes into the brain comes out of the mouth. I've had adult children tell me, I didn't know my mother knew that kind of language, because it's not the kind of thing that mom would have said anytime earlier, but there's no filter now. They also often have a lack of motivation. So getting them interested in anything, even if it was something they used to enjoy, is much more difficult now. And as I said earlier, they have difficulty sequencing. And that affects a lot of what we do every day. So what we consider a simple task may be too difficult for them now because they can't sequence. So saying to your dad, it's time to go brush your teeth, he has to understand a lot, and there's a lot of steps involved that we don't think about. He has to know what you mean by brush your teeth. He has to know, where do I do that? He has to know how to get to that place. And if he does make it there, there's lots of steps if you think about it. Turning on the light, finding the toothpaste, finding the toothbrush, turning the water on, taking the cap off, squeezing it. So, and I probably left out a few steps here. So they lose that ability to sequence, but we still want them to be as independent as possible. So we may need to break those steps down, break it so we're not giving them so many steps at one time. We may need to let them mimic us. So we go and brush our teeth with them so they can watch us. Eventually they'll need more help, our hand over their hand as they do it, at least to get them started. But at some point in time, as I said earlier, they will require that total care. Amnesia is more than just the loss of memory. Amnesia also is an inability to make new memories. So that's because the hippocampus has been involved, which is where you're taking in information and storing it in your memory. Once that's been destroyed, once it's been compromised, they can't make a new memory. So it's one of the reasons that they ask you the same question over and over again, or they tell you the same story over and over again, because not only do they not remember what you said, they don't remember what they asked, and they don't remember what they told you, because it just didn't make it in their memory when they said that. Amnesia also causes repetitive behavior. So when we see them picking at something, or picking up something and putting it down, picking up and putting it down, again, it's the amnesia that's involved. So amnesia is more than memory loss. Aphasia is the loss of our expressive and our receptive language. So we'll see a lot of folks start off with word finding problems. And so they might say to you, I need that, that thing, that thing, that thing, and it's yellow, I need that thing. And what they're trying to tell you is they need a pencil. but they're going into a long explanation because they've lost the word pencil. So we may see that word finding problem. Then we may see them speaking, and it sounds as if their words are slurred. It sounds as if they're intoxicated. We could see them having a conversation with you, and just like me, their hands are going, and they're smiling, and they're got all the intonations of a conversation, and they're so happy to be talking to you. And you're sitting there and listening and thinking, this makes no sense. We call it word salad. They're putting a lot of words together, but the words together don't make any sense. Eventually, what happens is they recognize that people aren't understanding them. And so they tend to self-isolate. And when they self-isolate, it can hasten the progression of the disease, because we know that individuals with dementia, we need to keep them socially occupied. It helps slow down the progression. Receptive language with aphasia is you're looking at them, you're talking, they're sitting there and they're nodding their head and they're smiling. And you say, did you understand that, Mom? And she says, of course I understood. I'm not stupid. But what you said to her sounded like wah, wah, wah. She heard the words. They made no sense to her at all. But she doesn't want you to think she's stupid. Now, research has shown that the ability to read seems to last the longest of the language skills. So you may have an individual can pick up a magazine, can pick up a newspaper, can pick up a book, and can read the words. They can read them out loud. But again, we don't know just how much of what they're reading they understand. So leaving a list of how to do something might not really be effective. So agnosia is the inability to recognize signals from our five senses and from the environment. It's also an inability to recognize common objects. And I always say that this is a dangerous time for folks to be left alone, because if we can't recognize the signals from the environment, we may not recognize the smell of smoke. We may not recognize what the smoke alarm going off means. These individuals also may not recognize a full bladder, which leads to incontinent issues. They may not recognize signs of a heart attack. I'm not saying they don't feel it. I'm not saying they don't feel a full bladder or they don't feel pain, but they don't recognize that for what it is. And that, combined with the loss of language, means they can't tell you what's going on. Apraxia is the inability to carry out purposeful movements and voluntary movements. So asking someone to get up, if they develop symptoms of apraxia, they may not be able to go do it. It's like the signal between the brain and the muscle in the leg is broken and they can't get up. It comes and goes in the beginning. It creates a huge fall risk, lots of falls. It affects all their activities of daily living. It can affect, again, because of that, it'll affect their toileting, their dressing, their hygiene. Again, they start off having good days and bad days. So today, Mom may be able to go up the steps. Tomorrow, she may not. But Wednesday, she may be able to use the steps again. So we have, these good days, these bad days. We have to be careful at this point when they're walking, because they may be walking and that signal may break. And then they're going to go down. We'll see them having an inability to catch a ball, inability to clap their hands. You may see them reaching for something on the table, but their hand is a good 12 inches away from what they're trying to get. Eventually, the apraxia will affect their ability to chew. It will affect their ability to swallow, and eventually affect their ability to breathe. So when we're talking about apraxia, we're generally talking towards the end of life. We're getting closer to the end of life at this stage. And this is definitely when you want to look at having a palliative care come in or hospice care come in, because they support you. And they're going to ensure that your loved one has the best care available, but they're there to support you as the caregiver. So these are like a common behaviors that we see a lot in folks that have dementia. But I want you to keep in mind, behaviors have a purpose, but they're not purposeful. If that's confusing. So they can't plan. Because they don't have the cognitive ability anymore, they can't plan to get on your nerve. They don't wake up this morning saying, I'm going to do everything I can to make my daughter upset. They can't do that. Now, do they make you upset during the day? Yeah, they can, but they can't plan it. It's the disease, and you always have to keep that in mind, that it's the disease. When I say behavior has a purpose, it's their way of communicating. When they've lost their language, when they can't tell you what's wrong, when they can't tell you something hurts, when they can't tell you that they're sad, when they don't have the words to tell you that they're angry or depressed, they're going to communicate to you with their behaviors. And so we have to play detective. We have to figure it out, what it is that they're trying to tell us. Most sudden changes in behaviors, if there's a sudden change in behavior in someone who has a progressive dementia, it usually means there's a medical condition going on, okay? Because remember how I said once we get that diagnosis, this can go on for 5 to 20 years? You're going to see gradual changes during this time. If you see a sudden change, generally it means something else happened. So if your mom is always pretty easygoing and she tries to cooperate and do what you ask her to do, and tomorrow morning when you get her up out of bed, she smacks you, that's a sudden change in behavior. And most often that's not caused by the dementia. Generally it's physical. 9 times out of 10, it's a urinary tract infection. Okay, it could be she's in pain. It could be, again, a medication interaction. So we've got to figure out what's going on. If she's prone to urinary tract infections, then we need to talk to the doctor about how we're going to treat that. Because again, it's a sudden change in behavior that is not part of a dementia. We've got to keep in mind that we cannot change this person. Just like I said in the beginning, we can't change the outcome. It is the disease that's causing these behaviors in them. And it's the environment that can bring out some of these behaviors. So rooms that are too bright, areas that are too noisy, rooms that are too dark, different things in the environment can cause them to become anxious or frustrated. So, excuse me. So again, we have to play detective in figuring out what's going on. Looking at some of the behaviors that we see most often, wandering. So wandering in itself, someone who just paces around or walks around the house, wandering itself is not a bad thing. As long as they're safe, as long as they're not trying to escape from the house and get out to a dangerous road situation. But wandering the house is not a bad thing. In fact, it gives them some exercise. The problem with wandering is that sometimes they won't stop long enough to eat, and they can be extremely tired at the end of the day. And so if they're wandering, we need to be able to get them to sit at some point in time and rest, and we need to make sure that we keep them hydrated and that we keep giving them food. Wandering can be boredom. They don't know what they're supposed to be doing. They may be hungry or thirsty and they can't tell you, and so they're just kind of walking around. Sometimes they have to go to the bathroom. So if we see them starting to fidget and start wandering around, may want to just guide them to the bathroom. A lot of times that will cue them onto what they're supposed to be doing. So again, if they're not in danger to themselves or they're not in danger to someone else, don't worry about the wandering. Just again, keep them hydrated, keep giving them something to eat. If they try to get out the door, put locks at the top of the door. They won't notice them if they're way at the top of the door. Put a black mat in front of the door, because a black mat looks like a big hole to them and they may not want to walk in front of that. We may also, if they're trying to get out, distract them, redirect them to another activity, and make sure that your loved one has a medical alert like bracelet on, so that if they do get out, the emergency staff can contact you and will know what's going on. So repetitive speech and actions, well, we talked about that a little bit earlier. It has to do a lot with the amnesia, but it can also occur when they become agitated or anxious. So when you see that happen, again, redirect. I'm going to be saying redirect a lot to you. Redirect, get them involved in an activity. When we get them involved in an activity, it has to be an activity that they can be successful at. We don't want to give them something that's beyond what they can do, because then you're going to lead them to frustration. So again, you have to constantly reevaluate where they are in the dementia, because what works today may not work next week. We want to look for activities that go along with something that they enjoyed before they were diagnosed. But we may continually have to break down those activities into something that they can accomplish now. Shadowing, if any of you has a shadower, that means that you can't even go to the bathroom without them standing out the door waiting for you. They are right at your back every step that you take. Someone who is shadowing, again, is not knowing what they're supposed to do. They realize, even with the dementia, they realize that they're an adult and there's expectations of adults. All of us have expectations. There's things that we're supposed to be doing. But with the dementia, they don't know what they're supposed to be doing. And maybe you look like you know what you're supposed to be doing and what they're supposed to be doing. And so they're going to follow you around just because they're unsure. We need to reassure them. Find something that they can do and reassure them. Agitation, they can become very irritable, sleepless, they can become aggressive. Usually it's caused by environmental factors, fear, fatigue, loss of control. Think about everything they've lost. Many of them have had to move out of their homes. They've lost the ability to drive and get where they want to. They've lost the ability to, a lot of times, determine what they're going to eat and when they're going to eat, when they're going to bathe, sometimes what they're going to wear. So all of these losses that they've had, we can do things such as reducing caffeine, sugar, junk food, which is tough because they keep the sweet taste buds for a long time, but try to reduce sugary and caffeine foods in particular. Reduce the noise in the environment, try to reduce the clutter in the environment. Use soothing music. Music works wonders. Use gentle touch, speak in a quiet tone. So even when they're agitated, you don't react with agitation. You're going to keep calm and speak quietly and empathize with them. A hand on the shoulder saying, I know this is hard, can calm down many of the situations. Sundowning happens a lot later in the day, usually between around 4 and 6:30 in the evening, early evening hours. It's a change in our circadian rhythms. So their circadian rhythm is telling them there's something they're supposed to be doing, because all of our lives we've had a change during that time of the day, but they don't know what they're supposed to be doing. So we see a lot of sundowning, which is, again, anxiety, wandering, telling you they want to go home, even if this is the home they've been living in for the last 30 years. we need to redirect. But the best thing to do about sundowning is kind of do a watch over a few days and see when it happens, because generally it's going to happen around the same time every day. So if your mom at 4:30 in the afternoon becomes agitated every day, then at 4:15 we want to get her involved in an activity. Okay, so we want to eliminate the behaviors as best as we can. Nutritional issues, they may tell you they're not hungry. They forget that they ate already, so they continually eat all day. They forget that they don't eat all day, and so they don't want to eat. Nutritional issues also may be they no longer know what to do with the utensils that are sitting on there, the fork, the spoon, the knife. They're not sure how to use them anymore. And sometimes the food itself, they're not sure of what to do with. Again, think back to children that are very young, the toddlers that you put the bowl in front of them that has mashed potatoes and peas. What do they do with it? They stick their hands in it. So we also need to look at the amount of food that we're giving them. We want to do much smaller portions. It's better to put very small portions and refill a tablespoon at a time than it is to put a whole plate, because it's very overwhelming to them. Go to finger foods. A lot of things that we eat can be made into finger foods, including things like pancakes and French fries and chicken nuggets and lots of things that we can just give them, and they don't have to worry about the utensils. If we're not using utensils, or we don't need all fork, knife, and spoon on the table, then don't put them on the table, because again, they're very overwhelming to them. Bathing is a huge issue. Again, I could spend a good 45 minutes probably talking to you about bathing issues, but there's a lot involved in bathing issues. A lot of our very elderly folks, our folks that are in their late 80s, their 90s, and those that are over 100, they didn't use showers when they were younger. And remember, now they've regressed. Even though they may be 90 years old, in their head, they're not 90 years old. They're only maybe in their 30s or their 20s. So they didn't shower then. They didn't use showers. They used tub baths. And oftentimes they didn't tub bath every day. That was a once or twice a week deal, and they bathed at the sink the rest of the time. So bathing's a huge issue. It can be a fearful issue for them. It can be too much noise in the bathroom. It can be too cold, too hot, because you're never going to get the temperature right, because their body temperature is never going to be, it's out of whack now. It's something else that's happened because of the disease. The other thing that's happening in the bathroom is, most bathrooms have mirrors, and a lot of bathrooms have big mirrors. And I didn't talk about this when we talked about agnosia, but one of the things that happens with agnosia is they don't recognize themselves in the mirror anymore. Because again, even though chronologically they're 85 years old, if in their mind they have already regressed back to the age of 40, they don't know who this old person is in the mirror. So they think there's a stranger in there. And who wants to be in the bathroom bathing with a stranger in there? So again, bathing, big issue. We can spend a lot of time talking about that. We need to do a lot of reassuring, letting them know they're safe, and also knowing they don't have to bathe every day. They don't have to shower. They don't have to get in the tub every day. We can keep them clean with sink baths. We can keep them clean using those nice wipes that you put in the microwave. We can also keep them clean with giving them their modesty. So letting them have a robe on, and we just open one part of the robe at a time to help them wash without exposing them. Because again, our older generation, they were very, very modest. We laugh now because we don't know what's going to happen as the baby boomers age, because they certainly didn't have the same kind of modesty that our older folks have now. So we don't know what we'll see then, but we do know that we need to respect our elderly now and make sure that we give them the privacy that we can do. Paranoia, hallucinations are not uncommon. Not everyone who has dementia has hallucinations or paranoia, but it's not totally uncommon. The best thing to do is reassure them empathize with them. If the paranoia or the hallucinations are very frightening to them, we need to talk to their physician. There may be some sort of medication that we need to use. But if hallucinations, my brother-in-law used to have hallucinations, but they were delightful and they made him very happy. And I talked to someone whose husband was having hallucinations, but he was talking to friends that weren't there, but they were for him. So if they're not frightening, just let them go. They're fine. But if they are frightening to them, or if it's making them very agitated or physical, then we need to definitely speak with a doctor. So communication skills in progressive dementias, and many of the progressive dementias, I'm going to tell you this, the person loses their peripheral vision. It's part of the disease. They lose the peripheral vision. So they can't see people that are coming to them from the side. If you're approaching from the side or from the back, they can't see you. And so we have to be very careful that we're always approaching from the front, because if we don't, we're going to startle them. If you startle an older woman, even if she doesn't have dementia, if you startle an older woman, there's a good chance she's going to fall. And we all know that if an older woman falls, there's also a good chance she's going to break something, which oftentimes is the beginning of a downhill health spiral. If you startle an older man, you're going to get smacked. The hand's going to come out. It's just an automatic response. He can't control it. He's not being aggressive. It's a response to being startled. So we don't want to startle. We always approach from the front. We need to have a pleasant look on our face, because even if they have lost their language, they're going to read your body language and they're going to react to your body language. So pleasant look on your face, approaching from the front. You get down to their eye level. So if they're sitting in a chair, you're not standing up above them. If they're laying in a bed, you're not standing over the bed. You pull up a chair, you kneel down, you stoop down, whatever you need to do so that your eyes are at the same level as their eyes. And you make sure you have that eye contact before you start talking. And you make sure that you keep that eye contact the whole time you're talking. Because once you break it, you got to start all over again. So again, approach from the front, smile on your face, get down to their level. And then when you're talking, you keep it simple. You never give them more than two choices. It may get to the point where it's a yes or no choice. If your words fail, we use gestures. Now, here's the other thing though, when you're talking to them and you're keeping it simple, and maybe you're asking, do you want tuna salad or chicken salad for lunch? As we age, even without dementia, it takes us longer to process things, to process words. With a dementia, it takes us even longer. So when we've said, do you want tuna salad or chicken salad? We have to give them up to 90 seconds to respond. Give them 90 seconds to take in our words, to think about what we're saying, and to come up with an answer. If after 90 seconds, they still haven't responded, we need to go back and ask the question in the exact same way, in the exact same tone we did the first time. Do you want tuna salad or chicken salad for lunch? Because if we change it and say, the tuna salad's on rye bread and the chicken salad's on a croissant, which one would you like? They're still processing the first thing that we asked them. And now we just threw a whole bunch more words at them. So keep it simple. If they don't respond in that 90 seconds, come back and say it the same way we said the first time. If after another 90 seconds they haven't responded, we need to figure out a new way to communicate. It may be showing them the tuna salad and the chicken salad, or the blue shirt and the red shirt, and letting them point to what they want. If it's gotten to the point in the dementia that making a decision between two things has become too much, we make the decision but we include them with it. So let's have the chicken salad today. It's really yummy. Or why don't you wear the blue shirt today? It makes your eyes sparkle. The cardinal rule of communicating with someone with dementia is we never argue, because you will never win. And even though they may forget the argument within 5 or 10 minutes, the emotion of anger stays with them for a very long time. And they won't understand why they're angry. They won't understand why they're upset, but they'll still have that feeling. You need to erase the word remember from your vocabulary. We don't say, don't you remember? I already told you that. Of course you know who I am. You remember me, don't you? We need to erase the word remember because they don't remember. The brain has taken, or the disease has killed the parts of the brain that have those memories. And so we need to erase that word from us. There's a magic phrase that we tell caregivers a lot. And I can say that it had worked for me. My brother-in-law had dementia, and it worked many times when I was with him. And that is a smile on your face, your hand out, and you say, come with me. Particularly at times when they're anxious and you're asking them to do something, and maybe because of apraxia, they don't know what your words mean. I mean, maybe because of aphasia, they don't know what your words mean, or because of apraxia, they can't get up at that point in time. Your hand out and a smile on your face, you look like you're a nice person, and you look like you know what I'm supposed to do, and they keep social skills for a long time. So their hand's going to go in your hand. You don't have to say anything else. You can get them to the bathroom if that's where you wanted them to go. You can get them to the kitchen table if that's where you wanted to go. And a lot of times by the time you get them there, that space will cue them to what they're supposed to do next. So if it's in the bathroom, they know they have to use the toilet, or they know they need to wash their hands. If it's at the kitchen, at the kitchen table, they know it's time to sit down to eat. So come with me with a smile on your face can work wonders. We talked about breaking down tasks, so make sure that if you're giving them something to do, that you're breaking down so that it's steps that they're able to complete. Just give a couple at a time. The other thing to do is, we all want to feel useful. If there was no purpose in our life, why would we get up in the morning? And the same goes for your loved one with dementia. They want to feel useful. So asking for their help can make a huge difference. Setting the table, folding the sheets, matching the socks, sorting the towels and the dishcloths and things like that. It doesn't matter if they do it perfectly. It gives them a sense of purpose. And then when they're done, we thank them for helping us. Because don't we all want to feel appreciated? So we give them something to do, we keep them active, something that they can do successfully, and then we thank them for their help. So I know we're getting close to time, so let me go just Department of Aging and Disabilities, lots and lots of resources. If you haven't looked at our website, please visit us. You'll see it at the end, but it's www.aacounty.org/aging. Lots of resources, but family caregivers, we have our respite care referral program where we screen and we train home care workers. So they do the same kind of work as home care agency workers do, but because they're independent contractors, they're a little less expensive than a home care agency. So, we have that available to give you some help in the home. Our National Family Caregiver Support Program, we have 2 caregiver support groups each month. We do monthly educational workshops. We do, if you have not attended our Dementia Live program, I strongly suggest that you sign up. We're now be able to do it virtually, but it's an experience combined with education. So for a brief period of time, we simulate dementia symptoms in you. so that you have a good understanding of what your loved one is going through. It's sort of an inside out program. You get to feel what it's like to have dementia for a very brief period of time. And then we talk a lot of what we've talked about tonight, but a little bit more in depth, talking about behaviors and communication skills. There's lots of community resources out there. I hope some of you have seen our directory for seniors and caregivers that comes out each year. We usually get them out at a lot of fairs and outreach programs. Of course, we're not doing them right now. I know they got mailed out to some areas of the county. I'm not sure which, but certainly if it's something that you need, it's available online. But if you're not able to get it online, you can contact me and I'll make sure that we get that to you. So that has a lot of the community resources in addition to talking about the Department of Aging and Disabilities programs. So finding care, remember I said at the beginning that you have to constantly be reevaluating how much you can do and how much you're able to continue doing. So there may come a time that you're saying, I need help. And it might be help for just a little bit of time each week, just so you can get a break. Or you may be needing help so that you can go back to work. So there's, in-home help, which is what we call the informal care, which is when you have, a friend or a family member that's helping to provide that care. Professional care is when you're hiring someone from a home care agency or a respite care worker. Out of home care, of course, a lot more expensive. Our medical adult daycare centers, which unfortunately are closed right now due to COVID. Assisted living facilities, sometimes those facilities will provide a 2 to 4 week stay. Again, limited now because of COVID, but sometimes it's maybe you need to go out of town, or maybe you have a wedding or something to go to. So a lot of times you can get some short-term respite care through the long-term care facilities. So it's important to plan ahead. I hope that you've done a lot of this already, keeping in mind that you cannot control what's happening, but you can prepare. So you can prepare for the medical, the legal, and the financial issues. If your loved one has a power of attorney, if they have prepared their will, if they have an advance directive, do you know where that information is? Do you know where to find it? Do you know where the financial information is and the important documents? You may want to meet with an attorney, especially if your loved one has gotten to the point where they can no longer make decisions. You need to find out what you need to do so that you can make those decisions if you haven't already been named as a power of attorney. Keep your loved one's social security numbers, their doctor's names and phone numbers, prescription information, insurance information, powers of attorney nearby where you can get them in an emergency. And if you are their if you have been named by them to make the medical decisions, you need to keep that advance directive copy. I always suggest you keep it in your glove compartment. Because if you're out at the office or you're out doing the grocery shopping and you get a call saying that your loved one has been taken to the emergency room, you don't want to have to go home and find it. You want to have a copy with you. So that's just a good place to keep it so that you have it in an emergency. And we were talking about this a little bit before everybody came on board tonight, but caregivers are like chameleons. You are constantly changing to meet the situation. And during your journey, you may morph from being the spouse or the child to being a parent, to being a nurse and a social worker and a therapist and an activity director and a companion, and to the ultimate decision maker. So you need to take care of yourself. You need to take one step at a time. You need to take care of your physical health, your mental health, your spiritual health. Don't hesitate to contact a professional support when needed. Exercise routinely, meditate, journal, if those are things that you enjoy doing. Identify a support system, and don't neglect your social network, which is good to see you all together because that means you're staying connected. Don't lose your social network. because you want them to be there when your care recipient is no longer there. Join a support group. If you haven't already done so, join a support group. Okay, again, the department offers 2 a month. We're during the daytime. I have a list of some that are in the evening. Most people, well, I think everybody's meeting virtually now. So join a support group. Again, I can't say this enough. Know what physical care that you're capable of doing, and don't push that boundary. Make yes your default answer. So when someone says to you, is there anything I can do to help? Yes. It has to come out automatically. Yes. Have a list of things that would be helpful to you. Maybe it would be helpful to you if someone prepared a meal once a week or even once a month. Maybe it would be helpful to you if someone was able to help with your yard work. Anything that you can think of, it's going to be different for everybody. Have a list. So when someone says to you, what can I do to help? You can show them the list, because maybe they'll say, you don't want me to cook for you, but I'll be happy to take your trash cans out on trash night so you don't have to go outside. So have that list and make yes your default answer. If you're dealing with an aggressive person and you find yourself losing control, get help. Show compassion, not only towards the person that you're taking care of, but show that same compassion to yourself. Okay, we don't do that. We beat ourselves up. We don't treat our loved one like we treat ourselves. So we need to show ourselves the same compassion that we're showing to our loved one. There will be sadness and there's going to be frustration on this journey, but you can also find joy. You can find some amazing and wondrous experiences if you're open to them. And to me, one of the best ways that you can find those experiences by using music. And again, that's another topic that I could probably talk about for 30 minutes. But music will work wonders. It will calm your loved one when they're agitated. It will get them up and moving when you're trying to get them up and moving, if you have the right tempo on. And if you're using the music from their lifetime, the music that they liked, it's a reminiscing experience that you can share with them. And sitting down for 15 minutes, playing some music and holding your loved one's hand can be a joyful and relaxing experience for both of you. So here is my information. So please feel free. You can call me, you can email me. Now I'm teleworking, so I will tell you, I get the emails quicker than I get to phone calls, but I'm more than happy to answer a phone call. If you have any questions about services for caregivers or what's going on in the department, if you just want to talk about a situation that you're going through, I'm more than happy to talk to you. I'm not going to tell you I have all the answers, because I don't think anybody does. But if I can't find them, I'll look for the answers for you. So again, thank you so much for having me here tonight. And I wish we were together, because I really like being interactive with people and but I'm glad that we were here. And I do see some smiling faces, and I saw a lot of head nodding tonight.